Hello, everyone. My name is Daniel Logan, and I'm excited to share our work on automating the extraction of postoperative outcome variables from the VA's cardiac VASQUIP dataset using supervised machine learning methods. The Veterans Affairs Surgical Quality Improvement Program, or VASQUIP, collects detailed clinical data for a full sample of cardiac surgeries performed in the VA system. This includes 187 variables, among them 22 postoperative 30-day outcomes. These variables are currently abstracted manually by surgical quality nurses, or SQNs, and they play a vital role in risk-adjusted outcome modeling for quality improvement and research. For a number of these variables, though, other data sources outside of VASQUIP record similar diagnoses, reoperations, and related pharmaceuticals to these conditions. So we are looking to see whether utilizing these outside data sources might help to predict this VASQUIP outcome as well, or better than the current nurse-abstracted method. To answer that, we focused on post-operative structure data, diagnosis, procedure, and medication codes which occurred within 30 days of surgery. We also considered exclusion for any pre-existing diagnosis codes to isolate true post-operative events. We trained a number of supervised machine learning tree-based models. Random forest and gradient boosted trees performed the best of these, and performed grid search for hyperparameter tuning. Our goal was to predict the outcome labels as assigned by SQNs, using F1 score as our primary performance metric. The results were mixed but encouraging. A few variables showed strong performance. For example, atrial fibrillation had an F1 score of 0.7 and performed better than previously seen by the rules-based methods. Reoperation for bleeding scored a 0.62 F1 score, which was hugely improved by the introduction of reoperative CPT codes from the Surg Intra Veterans Affairs table, and prolonged ventilator use over 48 hours came in at a 0.65 F1 score, also a big improvement over rules-based methods. Some other outcomes like cardiac arrest requiring CPR, tracheostomy, and renal failure had more modest results. Some of the other outcome variables not displayed here had very poor performance due to low counts of positive cases for training, as well as no clear association with the codes which we had available outside of the VASQUIP dataset. An interesting insight came from atrial fibrillation. Despite being well coded and frequently occurring, we still saw frequent disagreement between diagnosis codes and SQN labels. That underscores a key issue. Structured codes don't have a perfect match to that of the clinical judgments of SQNs. Looking ahead, we plan to expand feature engineering, for example, by integrating snippets from clinical notes or capturing temporal patterns. We're also exploring more advanced algorithms like extreme gradient boosting, and we're beginning to apply this framework beyond cardiac cases to the broader VASQUIP dataset. Thank you for listening to this talk, and happy Holman Day.